welcome to GU Oncology Now. My name is Laurence Albiges. I'm a medical oncologist, professor of medical oncology in Gustave Roussy, that is in France. It's the largest cancer center in Europe. It is my great pleasure to welcome you to this GU Oncology Now roundtable at KCRS. We will be discussing the treatment and the management of patients with non-clear cell renal cell carcinoma. And for this, it is my great pleasure to welcome my three guests. I will let them introduce themselves, and then we're going to kick off our discussion. Professor Zhang, Dr. Zhang.
Hi, thanks so much for having me, Laurence. Great pleasure to be here. I'm Tian Zhang. I'm a GU medical oncologist and Associate Director for Clinical Research at the Harold C. Simmons Comprehensive Cancer Center and UT Southwestern Medical Center in Dallas, Texas.
Thank you, Tian. Thank you for being here. Dr. Bari.
Thank you, Dr. Albiges. It's a pleasure and an honor to be here. My name is Shahla Bari. I am a physician scientist and a GU medical oncologist at Duke Cancer Institute. My lab as well as clinical practice is focused on renal cell cancer.
Thank you, Dr. Bari. Dr. Saliby.
Thank you, Dr. Albiges, for having me. Thank you, GU Oncology Now. I'm Renée Saliby. I've been a postdoc research fellow at Dana-Farber for the last 3 years, and I'm now a first-year resident in internal medicine at Yale New Haven Hospital.
Excellent. So thank you very much. And so without further ado, let us start on what is non-clear cell RCC.
Thank you. As we know, 75 to 80% of renal cell cancer is clear cell RCC. The remaining 20% is non-clear cell RCC, which encompasses a variety of different histologies. Among them, the most common of them are papillary cell RCC, the medullary RCC, collecting duct RCC, chromophobe RCC, as well as translocation RCC. And these classification was based on WHO guidelines that were there most up to date in 2016. Papillary cell RCC has also been historically subclassified into type 1 and type 2, though that pattern is now going away. So that is where we stand at in non-clear cell RCC.
So thank you, Shahla. So basically, this is something that is in constant evolution because we're defining new entities. We now have molecularly defined entity in the WHO classification. So we're getting to understanding better those different subsets among the non-clear cells.
Absolutely. Like in papillary cell, we now know that a lot of them are MET-driven, and therefore with those mutations, we have different treatment options. So yeah, we are going towards more molecular-based divisions than more of, based on distal or proximal or more of anatomy-based classifications.
So that's why some people say variant histologies instead of non-clear cell, because these are clearly different entities.
Yes.
And hopefully we'll get to different treatment at some point. But what about the prognostic of this non-clear cell RCC?
That's a very good point. As we know in clear cell RCC, the Memorial Sloan Kettering criteria, the IMDC criteria have been well validated, and they are able to be able to prognosticate a patient, their response to treatment. Similarly, as to clear cell RCC, in non-clear cell RCC, the IMDC criteria is still valid. Even the MSKCC has been valid, but not in the era of immunotherapy. What has been found out is that advanced RCC, global RCC criteria, as well as venous criteria have a more of a prognostic accuracy in variant histology, more specifically in papillary cell RCC. They have been found that there is a 77% sensitivity in advanced global RCC prognostic criteria, which includes, additional to IMDC, LDH as well as metastasis as factors. There is another group that has come up with a venous growth stratification, and that just includes 3 things. It includes the TNM staging, it includes venous thrombosis, and it includes the nuclear grading of the cancer. And based on that, they have been able to classify papillary cell RCC into low risk, intermediate risk, as well as high risk of recurrence. And it has a 75% prognostic accuracy in being able to say which patients are going to have a recurrence in papillary cell RCC.
Okay, so some advances in prognostic assessment, but in metastatic setting, we can use the IMDC.
Absolutely, IMDC is good for both clear cell as well as non-clear cell RCC.